Okay, we're gonna get started. So please, everybody, grab your seat. We're delighted to have John Gruber here in Toulouse from MIT. And John's work, we all know as health economists, but in addition to being a fantastic economist, he's also a delightful person. So thank you, John, for coming to Toulouse and for giving our second keynote for the conference. John, the floor is yours.
Thank you. Thank you so much, Angie. I have to start by recognizing that my wife is here, which is important for two reasons. First of all, it's one of the few times I'm nervous when I'm talking. Second of all, it's important because it helps explain in a way why my voice is gone. Not for the reasons you think, okay, but because my favorite sports team is the New York Knicks. And part of the reason they're my favorite sports team is because when I was a first-year grad student at Harvard, very frustrated. I hated the first year. I wanted to drop out. I decided that a convenient way to end my economics career would be to go to a Boston sports bar and root for the New York Knicks and get beaten up. I thought that would be like a way to symbolize the end of my first year. And it was at that trip to the bar that I met my wife. So the New York Knicks are a very important part of my life. And the reason that matters is because I flew home on Saturday to New York for one day to go see the Knicks win the championship, and that's when my voice is gone. So I apologize. I apologize, especially conference organizers. I've never lost my voice before. I did not know this was a risk. So I'm very apologetic to the conference organizers for not having a voice. Okay, so I want to talk today about research I'm working on with Mark Shepard at Harvard University. This is going to be a chapter in the Handbook of Health Economics. We were tasked with the modest question of what is universal coverage? Universal health coverage. So we spent a lot of time thinking about this, and we think we have some interesting insights I'd like to share with you today. Let's start with the simple fact, which is, why do we need health insurance? This is data from 5 different countries on percentiles of health spending relative to median income. So what you see is in every country, the bottom 50% of the population spends virtually nothing on healthcare. Okay? By the time you get to the top 10%, in every country, the top 10% expenditure on healthcare is larger than the typical median income. By the time you get to the top 1%, the top 1% of expenditure is at least 3.5 times median income. In the US, it's 8 times median income. This is risk, okay, in a picture. This is what people want to insure. Unpredictable, enormous risks. So health insurance is necessary. Okay, this kind of distribution of risk is around the world. Obviously, it's wider in countries. This obviously lines up a bit with healthcare spending as a share of GDP. But the bottom line is, even in countries with healthcare is not a large share of GDP, there's enormous risk. And that's why health insurance is necessary. So what is universal healthcare coverage? We have our own definition, which is that no one faces unaffordable costs to get essential healthcare. Now, this raises 3 questions. First, what is no one? Okay, do you literally mean no one? In particular, what about undocumented residents of a country? Second is, what is affordable? Neil Mahoney will understand this especially. Affordability is a term with which people are obsessed. Guess what? That's not an economics term, folks. Affordable has no meaning. None in economics. It's a term of art. So how do we think about affordable in the context of economics? And the third is, what is essential? What is essential healthcare? Who should decide? And definitions can change over time, like they have with pharmaceuticals. So these are the 3 questions you need to answer to get to universal health coverage. So in practice, what we're going to do in this country, in this paper, is we're going to focus on, in this paper, we're just going to focus on relatively high income countries. It's a sample of countries with incomes of at least $10,000 per capita. Okay. For very poor countries, I feel like there's a separate set of issues about capacity that we're not going to get into. This is a set of countries that have the capacity to have universal healthcare coverage. Okay? Indeed, virtually every OECD nation has universal coverage, but it comes on very different flavors. And we're going to develop a new taxonomy. It's related to the old TR Reid taxonomy, but we think it's a more useful taxonomy for health insurance coverage. Previous taxonomies about healthcare delivery as well as coverage. For focusing on coverage, we're going to develop a new taxonomy between 3 types. Universal public coverage, which is countries where people are automatically enrolled at birth into a public plan that covers their costs. Okay. Mandatory multi-payer systems, which are countries, this was mentioned yesterday when we discussion of the Netherlands, countries that have multi-payer systems, yet everyone is insured. And then the last capacity we'll call incomplete and fragmented systems. These are systems which lead many people to fall through the cracks. Okay? What we do is we're going to start by reviewing insurance market failures and arguing, importantly, between the difference between universal healthcare access and universal healthcare coverage. A lot of the market failures we talk about in healthcare are really about guaranteeing access. But if you really want to justify universal healthcare coverage, it has to be on grounds of externalities or internalities. The second point we'll make is we'll set up this taxonomy I described. Then we'll review key aspects of health insurance systems. Okay, who is covered, what is covered, how much is paid out of pocket, and we'll conclude with what is necessary and what is not for universal coverage. Okay, so let's start with market failures in insurance. As I showed, healthcare risk is large and unpredictable. There should be, and there is, large demand for insurance. But why does government need to be involved? After all, private insurance expenditures in the US are in the order of $2 trillion. So why do we need government involved in the provision of insurance? Well, this all goes back to Ken Arrow's Everything in Health Economics Does. Ken Arrow talked about all the ways that healthcare markets are screwed up. Talked about imperfect competition. Most hospital markets, at least in the US, I presume around the world, are very concentrated. There's imperfect information, lots of evidence for adverse selection. My colleague, Amy Finkelstein and Laurent Einaf have done fantastic work in this area, as we all know. The key point is these can justify government regulation and provision of universal healthcare access, but none of these failures justify actually going the way to universal coverage. If you have universal access where you can, that is enough to address these problems. If you want to actually argue universal coverage, you need to go on to the next step, which is that requires either externalities or internality justifications. Okay? In my opinion, externalities are not large enough. There's two types of externalities. There's physical externalities. I don't have health insurance, I get sick. Okay? That is not very large in practice. I mean, 99.9% of healthcare spending is not on communicable disease. Okay, if that was really the main thing we worried about, we could deal with that by just vaccinating everybody and having free primary care visits. Okay, there's financial externalities. These are larger, but they're still not enormous. Once again, in the US, which is, we're talking about $30 billion a year of spending on uncompensated care for uninsured people. Okay, $30 billion is nothing in the context of government policy, certainly given the enormous battle you would have to get from universal access to universal coverage. It's a trivial amount of money. We think that if you really want to justify universal health coverage, you need to rely on individual choice inconsistencies. And it's clear that individuals are not making rational decisions about health insurance. Okay? We have evidence. Things like very small premiums or copayments matter enormously. Very small premiums matter enormously for health insurance coverage. Taking someone from $0 to $5 has an enormous effect on the decision to purchase health insurance. That's irrational, given the value of health insurance. Defaults matter. Defaulting people into health insurance with an opt-out has a massive effect on whether they sign up for health insurance. There's the evidence that I've worked on and others have worked on that intensive margin choices are highly inconsistent, which suggests that the extensive margin choices will be inconsistent as well. And basically, there's lots of evidence that expanding health insurance coverage, even in a system of universal access, when you expand coverage, it improves health cost effectively. So we think that if you want to go from universal access, which I'll argue is largely where the US is today, we largely have universal access, at least for documented citizens. If you want to justify the next step to universal coverage, I think you need to lean on internalities. Here's our coverage system taxonomy. Okay. And really, the only way we differ from the classic T.R. Reid taxonomy is we collapse his first two categories into one category. The T.R. Reid taxonomy sort of breaks these first two categories apart based on whether there's public delivery of coverage, like in the UK, or just public insurance, like in Canada. We think that's a false dichotomy when it comes to coverage, because the truth is, in every country, there's public and private providers everywhere. For coverage, what really matters is whether you're automatically enrolled in a public system from birth. Okay, as you are and whether the basic insurance is all publicly provided. There can be supplemental insurance, it's private. When you're automatically enrolled in a public plan, that is the first category. And that's most of the countries in the OECD. Okay. The second category, which we find the most fascinating, is mandatory multi-payer systems. These are systems where you are not automatically enrolled, where there is not a single payer, but where no one falls through the cracks, where everyone is insured despite the fact that they're not enrolled from birth. And we talked a little bit about that yesterday with the presentation on the Netherlands. We'll talk more about that today. And then finally, we have non-universal systems. They're either disorganized or they're incomplete. These are less regulated. There's much larger role for for-profit. Fragmented systems are things like the USA and China, and incomplete are places like Mexico, Argentina, and Chile. So what I want to do now is go through a series of facts, categorizing the countries, and show you what lines up with these categories and what surprisingly doesn't. So let's start with, I already talked about this. Let's start with coverage. Let's just go right here. Coverage. So what you see here is coverage of uninsurance rates are essentially zero for legal residents. Okay, in every country that's either universal public system, mandatory multi-payer. The only countries that have meaningful uninsurance rates are in that last category, incomplete or fragmented, for legal residents. But if you actually then add in all residents, there starts to be some uninsurance. So one feature we'll highlight is that in every country, there's less than perfect, in most countries, there's less than perfect coverage of undocumented individuals. And you see that, but the numbers are still very small. Okay? Health spending is a share of GDP. Here, basically, the pattern is a little bit different than you get. You get some of the incomplete fragmented countries are at the bottom, China, Mexico. And then, of course, you get the outlier, the US. And therefore, I've tried to highlight France as well, given where I'm presenting the talk. France has pretty high spending as a share of GDP. Let's go back to France on the uninsured. France on the uninsured is pretty low, even when you add in the undocumented, 0.4%. What's striking about healthcare spending is really, when I look at this graph, my takeaway is basically how flat it is in the middle. That basically the vast majority of countries spend, between 8.8 and 12.3% of GDP on healthcare. There's some outliers at the bottom. There's the US at the top, but it's pretty flat. And I would say it's sort of not super highly differentiated across the categories. Then we get to public versus private financing of healthcare. Here it lines up much more as you'd expect, although not perfectly, with the categories. The automatic public systems have a much higher public share. The multi-payer systems have a much higher private share. And the non-universal systems have the highest private share. But once again, even in the country with the highest private share, it's only 55%. Okay, there is no private healthcare in the world, purely private systems. Okay, as much as conservatives would like to pretend there is, Singapore, which is not in this chart, probably comes the closest, and we'll talk about Singapore. That's a particularly odd case. But the bottom line is, even in the countries like the Scandinavian countries, still 1/7 of healthcare spending is privately financed. And then it goes down as you go along. Here is, to my mind, the key insight we want to focus on in this paper. Out-of-pocket share, which completely does not line up with anything, with the systems. Look at the two lowest out-of-pocket share in the world, France and the US. Two countries that are totally different in other aspects of this. Okay, you've got countries, you've got Taiwan, which has a public single-payer system, has 38% out of pocket. France, which is a public payer, single-payer system, is 9% out of pocket. You've got Mexico at 41%, the US at 11%. These are really striking numbers. Once again, none of these numbers are hidden. This is all Commonwealth data plus a little work on our own to get countries the Commonwealth doesn't cover. But this to us is a really striking fact we want to focus on in this research. How do you get this interesting spread in the share of healthcare spending that's out of pocket that doesn't seem to line up at all? Okay. Financing is varying across different countries. Universal public systems generally rely on general taxation, but there's a broader mix in the multi-payer systems. A larger role. So what you see here is general taxation is blue. Payroll and social insurance is a much larger role in the mandatory multi-payer systems. And then you've got a strong mix in the USA. Okay. Now I want to dive into a little more detail on some of these things and talk about them. Let's talk about who's covered and uninsured. So basically, like I said, essentially, you've got universal coverage. You've got essentially zero uninsurance rate for legal citizens in all countries in the first two categories. But there is widespread non-coverage of the undocumented. This is an interesting fact. The bottom line is there's just not that many undocumented in most countries. In the US, my estimate is probably of the uninsured today, between a quarter and a third are undocumented. So a lot of what's going on in the US is not so much a different set of rules, it's a larger share of the undocumented population. So among the documented population, our uninsurance rate is much, much lower. Okay? So still high, but lower. Okay, now let's talk about the US for a minute. Since we're sort of the exceptional case here, let's talk about the path that we've taken, because this will be important for thinking about how hard it is to get to universal coverage. Most of the other countries followed a sort of politically uninteresting path, which is they just passed universal coverage at some point and they were done. Okay, the US has a more interesting path with four key developments. The first was during World War II, we moved to an employer-sponsored insurance system, okay, which was really predicated on two developments. One was wage and price controls during World War II, which led employers to try to avoid them by offering benefits like health insurance. And the second was a decision by the IRS to allow health insurance to be non-taxable compensation. That is a feature of our system which is widely criticized. It is cost us about $300 billion a year in foregone tax revenues. To be clear, other countries in the multi-payer system also have this feature to some extent. We're not alone in that system. Then in the 1960s, there was the introduction of Medicare and Medicaid. The only thing I called my undergraduates responsible for is understanding the difference between Medicare and Medicaid. Medicare is health insurance for the elderly. Medicaid is health insurance for the poor. Don't get me started on the poor elderly. That's confusing. But there's Medicare and Medicaid. They were introduced in the 1960s. They were then dramatically expanded in the 80s and 90s for two groups, for children and for pregnant women, to politically sympathetic groups. And then finally, the Affordable Care Act in 2010 essentially filled the rest of the access gaps, especially when the system was in place under President Biden, as was discussed yesterday in the presentation. Essentially, we had a system where no documented American could not, where every documented American could get health insurance for 8% of their income or less. Full stop. Okay? That's universal access. Now, that's been backed off now that the extended subsidies are gone for some, there's still universal access, but now with that cliff reintroduced that was discussed yesterday, that 8% number can be more like 25% for some people. But it's still universal access. Okay? Everyone is guaranteed access to health insurance. Although it can be very unaffordable for many. I think no matter what we define, how we want to define affordability, 25% is unaffordable. Okay, but due to these expansions, it's a very fragmented or uncoordinated system. These piecemeal expansions led to this very fragmented or uncoordinated systems. And within this system, any attempts to move towards broader coverage have largely failed. Take-up is highly incomplete. Take-up of health insurance is highly incomplete. And trying to get to mandated coverage is too politically unpopular. So here is kind of how the US health insurance system looks like today. You've got about 50% of people in employer insurance. About 6% are in non-group. That's up a lot with the passage of the Affordable Care Act. That's largely in the ACA exchanges that allow people to buy health insurance. About 20% in Medicaid, health insurance for the poor. There you go. About 14% in Medicare, health insurance for the elderly. There you go. About 1% in military insurance, about 9% uninsured. But here's, I think, a more useful way to think about. Here's a more useful way to think about how the U.S. healthcare system works. If you're 65 plus, you get Medicare. This is single payer for the elderly. If you're less than 65, your employer-sponsored insurance offered by a job increases with age. This is not a technically sophisticated graph. It's illustrative. If you're less than 18 and poor, you get Medicaid and CHIP, which is an expansion of Medicaid. If you were between 18 and 65 and very poor, under the ACA, you get Medicaid. And then there's the individual marketplaces in between. But the bottom line is there's lots of holes. And this is the theme that we want to emphasize in doing this research, which is the theme we call seamlessness. But I think a better decision may be sort of a theme of filling the cracks. It's not that cracks don't exist around the world in health insurance systems. It's that other countries fill them and we don't. The US doesn't. We're in France. You do. The US doesn't. Okay? That the cracks exist and they're unfilled in the US. These cracks are filled in other countries. Okay? So basically, in the automatic public system, it's easy. You're in when you're born. Okay? There's no crack to be filled. Okay? Now, there is movement around the country. There is some disruption when you move, but they're very aggressive about making sure those who are moved immediately re-signed up for the regional plan. The mandatory multi-payer systems, this is what's interesting. In many ways, they're not that different than the US. They have the same sort of system but the difference is there's a social acceptance of mandated coverage through a mix of auto enrollment via employers, active enrollment, and premium collection. And basically, the point is they have a default rule to make sure people are insured. So let's talk about how this works. So here's the UK. Here's an example for a typical universal public system. Okay? Typical universal public system. If you're an ordinary resident in the UK, then you're automatically entitled. Okay? When you're born, you get assigned an NHS number. Done. Okay, you get assigned an NHS number. Your one practical step is you do have to register with a GP. Okay, but that's free and open to all. And then it's free care at the point of use. Okay, it's the simplest possible system. There's no enrollment to enforce. And there's emergency care for everyone. Okay, so here you have, and we'll find this common across all countries, including the US, free emergency care for anyone who needs it. So that's simple. Now let's talk about Switzerland. Okay, here's a mandatory multi-payer system. How does Switzerland work? There's a legal mandate to be insured. Okay, there is an automatic pathway, which is employees are automatically registered by the employer. And there's an active registration pathway, which is you pay directly. So automatic pathway, no problem. Here, people don't register, right? That's going to happen. If you're not defaulted at birth, it's going to happen. What do? First, there's reminder notices, okay? Warning you that you'll pay a fee if you're not insured. Second, there's penalties and arrears. We penalize you and we keep track of those. They penalize, keep track of those penalties. Third, there's restricted coverage. If you haven't registered, then you can't access aspects of the system and they start coming after you with debt collection. Okay. And fourth, there's actually garnishment and seizure of assets, garnishment of wages, seizure of assets if you're not insured. So basically, there's two backstops here. One is retroactive enrollment. Once discovered, so if I find you're on a roll, we get you, and we make you pay back the fees you missed with some relief for poor people. And there's also always emergency care. Okay? So the bottom line is, Switzerland's system not so different from the US, but there's a social consensus that they'll take the steps necessary to make sure people have coverage. Okay, so that's the first question, who's covered and how do they get there? Okay, So the first thing was when I said the definition of universal coverage was everyone. Well, this is how everyone's defined. The next step is essential healthcare. What is essential? Well, this is a list of the services covered by countries in our sample. What you see is there's a broad consensus in every country that essentially all care, primary care, hospital care, specialist care, and by and large mental health, with the one exception of mixed coverage in Australia, should be fully covered with no exceptions. This is striking. There's actually remarkably little variation in what insurance packages cover. A lot of focus in the US is on skinny packages and how we can make coverage skinnier. That's really a bunch of bullshit, because the truth is almost all insurance in America covers almost all the exact same stuff. Okay, the skinniest is just about financial cost sharing. The truth is all the plans cover most of the stuff. Where differences start to emerge, prescription drugs are less well covered, less universally covered, although still mostly covered around the world. Dental care and is much less covered, along with vision care and long-term care. Now, long-term care, there's often coverage outside of the health system, but this is within the health system coverage of long-term care. So that's where differences start to emerge in services covered. But there's really an incredibly broad consensus across very different countries on what makes health insurance. Okay? The consensus, the most interesting place the consensus breaks down is prescription drugs. Now, how is this determined? Okay? Well, basically, let's focus on pharma. Because remember, when these systems were set up, outpatient pharma was not a big deal. Okay? Before the 1970s, outpatient pharma spending was a very small share of medical spending. And it's really in the last couple decades, it's become quite a large share. So some of these countries were set up not including pharma. Okay? And what's quite striking is the mandatory multi-payer systems, they often covered RX from the start of their systems. They started later and typically covered from the start. But the automatic public nations, often built around public hospitals and doctors, did not. Pharma was a later add-on in their systems. Okay? So in Canada, they was covered much later. In the UK, it was covered early, but with cost sharing. Okay, so that is sort of the interesting difference in pharma. The other big difference on benefits is how far does choice extend? Okay, in universal public countries, there's little or no choice of the basic plan. You get a basic plan, you're assigned at birth, you're done. Okay, but in the mandatory multi-payer countries, there's some choice in your basic plan. Okay, France and Japan, there's not real choice. Germany has an interesting system where the basic, for most people that enrolled in a single basic plan, but if you're above a certain income level, you get to choose, which is kind of interesting. Okay, and then in the other multi-payer systems, there's real choices. Okay, there's real choice across plans. Individuals get to choose, once again, with this backstop that you're mandated to choose something. Now, the US is both similar and different. Most insurers cover a similar set of benefits, but insurers vary a lot more widely than they do in other countries. In particular, in terms of, but they don't vary in what they cover. This is the key thing. The big difference across plans in the US is not what the plans cover. It's in things like how broad the network is, how large the cost sharing is, and how aggressively they manage utilization. Those are the big differences. Okay? And the degree of plan choice varies a lot in the US. If you're an employer, you typically have one choice. Not an employer, you may have many. Okay, now, that is on paper. But let's talk about it in practice. On paper, in most countries, most things are covered. In practice, there are critical limitations. Okay? So, for example, there's limitations in quality and convenience, like wait times. Okay? And there's limitation in the quality of care. Okay? And I want to talk about these limitations for a few minutes. Let me say this is very interesting. When we go back to this slide here, sorry, that's a long time back. I shouldn't have done this. Okay, we go back to this slide. You look at the last column. That was based on our own calculations. We then went and looked, and we were spot on with the OECD. We're within 0.1%. But we're way off from WHO. If you look at WHO rates of universal healthcare coverage, they look nothing like this. Why? Because WHO factors in all these limitations. WHO says you only have universal coverage if you're unlimited. So WHO tries to have an estimate. So if you look at WHO lists, they've got countries like one of the Scandinavian countries that 20% has 80% coverage, where we say it's 100%, because they're saying it's hard to access some of the care. So the question is, when you define universal coverage, we would say it basically comes back to, what does it mean to be able to get essential care? Okay. So for example, if you look at waiting times, there's a lot of variation in waiting times. Once again, not super correlated with the healthcare system. So you've got Australia and Italy, two different countries with national public systems and dramatically different waiting times. You've got waiting times for hip replacement surgery. The same ones tend to be at the top. The top tends to be Chile, Norway, Australia. The bottom tends to be Italy, Denmark, tends to be at the bottom, okay, for the waiting times. Okay, so waiting times is one limit. Now, one way countries get around this is they allow an escape valve, which is they allow supplemental coverage. And this is a key feature of universal healthcare systems. Okay, so in France, you have the mutuelle system. In Canada, there's coverage of excluded drugs. In Australia, you can buy supplemental coverage to get private hospitals, nicer hospital rooms. My favorite is Singapore. In Singapore, if you don't buy supplemental coverage, you don't get an air-conditioned hospital room. And I've never been to Singapore, but I can't imagine anything worse in life than being in an unair-conditioned hospital room in Singapore. Okay, so basically there's various ways that they basically supplemental coverage basically top up your coverage. Okay, but that leads to the fascinating fact, which I highlighted before, which is this very strange pattern of out-of-pocket share of healthcare spending that doesn't seem to line up with anything else. Okay, you've got the US and France have the lowest, despite having two different systems. Others have higher, and there's no clear relationship to system type. So what's going on here? What's going on here, and if you look at it by service, you see that it's also like all over the place. Brazil's the highest for pharmaceuticals, but it's in the middle for inpatient care. You've got Switzerland is at the bottom of outpatient care of pharmaceuticals, and near the top for outpatient care, and back in the middle for dental care. It's all over the place. So what's going on with out-of-pocket spending? This was the real enduring mystery we faced in doing this. Well, really, there's two things that out-of-pocket spending represent. The first is cost sharing in the basic system. But the second, we would argue, as economists, is a market-based representation of the limitations in the system. That essentially, we have, in some sense, we think about input and output regulation, right? You can regulate inputs, you regulate outputs. Inputs would be, you do things like number of doctors per capita, number of hospitals per capita to get access. Output might be things like waiting times. This is the ultimate revealed preference measure of limitations in the system, which is how much do people spend out of pocket trying to bypass the system, okay? Now, the problem is decomposing these is hard. And this is what we spend a lot of time on. And it'll be much more detail in the paper, but let me go through two examples of what we've done to try to decompose these. Let's start with Italy. Italy's interesting. Italy has a universal healthcare coverage system, but pretty high out of pocket. They're at about 22% out of pocket, or about more than twice the US. Okay, so what's going on with Italy? Okay, so they have a universal healthcare coverage system with minimal cost sharing. Okay, if you look at the system, it's like a couple euros to go see the doctor. And yet 22% of their healthcare spending is out of pocket. Basically, essentially, people are paying to bypass the basic system. There's two types of things. They're paying to bypass the basic system. They even have something called intraomena, private doctors practicing in public hospitals. So you get shorter wait times and faster care. And there's also, you're paying for care the basic system excludes, like non-essential drugs, vision, optical, long-term care. Now, if you consider basically the question is, does OOP buy faster care? Basically, here's what's quite interesting. Italy actually has relatively low waiting times, as I said before. So what seems to be happening is that Italians are spending a lot to pay their way to shorter waiting times. Okay? Now, is that a violation of universal health coverage or not? That depends on your definition of essential. If essential means immediate access to care, then that's not universal coverage. That's what the WHO would say. If essential means you can get it, but we don't care about waiting times, then Italy does have universal health coverage. So basically, it depends on how you want to define that. Switzerland is a case where there's much higher out-of-pocket spending for the basic system. And here's the one place we're actually able to do the math. We collected all the data and did the math. And what we find is that on the order of 35 to 40% of out-of-pocket spending in Switzerland is actually co-payments for the basic system. And the rest is buying your way out of the basic system. Okay? So the bottom line is most of this high out-of-pocket number seems to come from people buying their way out of the system. Now here, what's interesting is satisfaction with care is much higher in the multi-payer countries. Despite the fact the universal care coverage countries, it's simple, you're enrolled from birth. They actually have some of the lowest satisfaction with their healthcare system. Italy at the bottom. Once again, interesting case. Italy, universal coverage, virtually no copayment, incredibly unsatisfied, very high out-of-pocket spending. So once again, is that universal health coverage? That's in the eye of the beholder. Okay? France has fallen markedly in satisfaction. I don't know what's going on in France. Used to have a very satisfied population, 81%. Now you're down to 60%. I'm not quite sure what's going on with satisfaction with healthcare in France. And the US is in the middle. Okay? So once again, another way to think about universal coverage is how satisfied are people with their healthcare coverage. By that measure, the US is not doing too badly. By that measure, the US is doing better than France. Okay? So once again, there are multiple ways to think about this, about what is a system, a desirable system. Okay, so I want to conclude this part of the talk by saying what is necessary and what is not necessary for universal healthcare coverage. I'll make sure I run out of time. What's necessary is not necessary universal healthcare coverage. We think three things are necessary for universal healthcare coverage. You need a social consensus for seamlessness. You don't need a single payer. I think Bernie Sanders has done an enormous disservice to the left in the US by saying that basically by tying universal coverage to single payer. You don't need single payer to have universal coverage. Okay, those are two separate things. What single payer systems are doing, when you say the term single payer, you're really mixing three concepts: universal coverage, regulated prices. Okay, universal coverage, regulated prices, and I forget the third. Oh my God, who was the guy who forgot that in debate? I'm like the Texas guy who forgot the third point in the debate. Anyway, the bottom line was, whatever. The bottom line is he's mixing up universal coverage with, and one payer. That's the third thing. Okay, single payers, one payer, universal coverage, and regulated prices. Those are three separate concepts, all of which you can have independently and can be mixed in any combination you want. Okay, in France, you have a Bernie Sanders style single payer system. You have one payer providing universal access to the regulated prices. Okay, but you don't have to have that in Switzerland. You have universal coverage and regulated prices, but not one payer. The bottom line is these are all independent features. What you need, but what you need to have universal coverage is a social consensus for a seamless system. That's the key requirement. The second is empirically, not theoretically, but empirically, you need an escape valve. Every country has universal coverage allows supplemental coverage and has a large amount of out-of-pocket spending. There's an escape valve. You cannot try to regulate everyone gets the same amount of care, or at least no country's tried to do that. Canada probably came the closest. For many years, Canada did not allow people to top up their health insurance, but they've even caved on that now. Okay? And the third thing you need is a large investment in public spending. None of the countries that have universal coverage do not massively invest in their public health systems. Okay. What do you not need? You don't need a single payer. You don't need a particular form of financing. It could be tax financing, employer financing, individual financing. That's not necessarily a single payer. And quite frankly, in our view, you don't need the highest quality of care for everyone. Most countries, people would agree, have universal coverage, have a lot of people buying their way out. We have these sort of market-based indicators that people aren't satisfied. Okay? So that's the first thing I want to conclude on that paper. But I want to talk about, looking forward, two big issues that all the countries face, regardless of universal coverage. The first is population aging. Okay, we know these facts. So these facts are all from a book I wrote with Kathleen McGarry called Long-Term Care Around the World, where we put together a team of experts from 10 countries to review their long-term care systems. We know the population is getting older, and we know that the share 65 is getting older in all these countries, and the share of that group that's over 85 is also getting older. We are about 10 years from peak demand for long-term care. Okay, if you look at the baby boom hitting 85, about 10 years away from that. The key feature of why people need long-term care, okay, now we talk about population aging, we talk a lot about pressures on pension systems, but I want to focus, and this book focuses with Kathleen on pressure on long-term care systems. And that pressure comes from the fact that disabilities are highly concentrated with age. So this is in the US, 65-year-olds, among 65 plus, 3/4 of them have no limitations. ADLs are limitation or activity of daily living. That's unable to toilet, bathe, get dressed, feed yourself. IADLs are instrumental activity of daily living. That's an inability to drive, to balance a checkbook. These are sort of less severe barriers, but still barriers. 3/4 of those 65 plus have none of those problems. However, only 42% of those 85 plus have none of those problems. And you can see among those who are 85 plus, 17% have 4 or more limitations ADL. So basically can't function at all, can't bathe, can't feed themselves, can't toilet. So as we get older, these problems are going to get more severe. Okay? Here's what's interesting. We talk a lot about the variation in healthcare spending around the world. We don't talk enough about the variation in long-term care spending around the world. So basically in 2019, there's a lot of variation in how much people spend in long-term care. Much like healthcare, there's sort of a broad middle of around 2% of GDP. But there's variation with countries like Spain, like the US, I'm sorry, spend only 1.3% of GDP on long-term care. Spain at 0.9%. The Netherlands, 4.1%. The Netherlands has a 10% payroll tax just to finance long-term care. Okay, they spend a lot of money on long-term care in the Netherlands. Okay, and you see it's growing everywhere, but the rate of change differs a lot as well. So long-term care is a growing share everywhere with variation that we can study. The financing of one commonality is long-term care financing is mostly public everywhere. Even in the US, it's 71%. The lowest is Singapore, 51%. The vast majority of financing of long-term care is mostly public, and then private insurance is negligible everywhere. There's almost nowhere has really created a successful private insurance market for long-term care. It's mostly public and out of pocket. But countries vary a decent amount in how they deliver long-term care. So this shows spending on nursing home care and care in home. What you see is there's a lot of variation in the share at home. You've got some countries like Spain where this is, by the way, this is formal care spending. This is excluding informal care. I'll come to that next. Spain, among those used formal care, the vast majority are in nursing homes. On the other hand, if you look at, I'm having trouble reading the rows here. If you look at Japan, the majority are at home. So there's a lot of variation in where people are getting their formal home care delivered, both in terms of nursing home and at home. But what's really interesting, I don't have this here. I should have had this. There's also a huge amount of variation in how much care is formal. There's a lot of variation in how much informal care. So while Spain has most of their formal care is delivered in nursing homes. A huge share of their care is informal, of the healthcare delivered in Spain is informal. And indeed, if you go back to these percents of GDP that I had a minute ago, what we did in our paper in our volume with McGarry is we then added in evaluation of time providing informal care. We find that that sort of equalizes these numbers considerably. That a lot of the countries that spend little on formal long-term care are devoting a lot of human resources to informal long-term care. And we're going to need, this is a growing issue worldwide that countries are going to face, is how are we going to finance this growing need for long-term care? And to what extent we continue to rely on informal care, which is costly. It's deterring the ability of people to devote their labor supply to where it may be best targeted. So that's one issue I think we have to face in all these systems. The second issue we have to face is radical healthcare innovation. Okay. Cell and gene therapies for rare disease are one example. My favorite example here is Zolgensma. Zolgensma is a drug for spinal muscular atrophy, which is a terrible, SMA is a terrible disease. Kids are dead by 2. You can imagine nothing sadder. Okay. Well, we've cured it. There's a cellular therapy, which is injected into babies, which can actually cure them of this disease and keep them alive. And it costs $2.1 million. Now, $2.1 million is actually a pretty good deal for saving a baby's life. Okay? But it's a big number. So what do you do? This is a challenge. We talk about we talked yesterday about drug price regulation, MFN, and other things. I think the challenge is what Europe, I think, has done very well relative to the US is technology assessment and thinking about setting prices as a function of value. And a lot of the reason drugs are cheaper here is because, quite frankly, they're not nearly as valuable as the prices that are set in the US. The problem is these drugs are as valuable. Zolgensma was reviewed by NICE, was priced at $2.1 million in the US. It was reviewed by NICE in England, and they priced it at $2.1 million. That almost never happens, okay? Because it's worth it, okay? So what are we going to do when we have part of the way that Europe has kept its costs down is through, I think appropriately, assessing that we're overpricing things. What are we going to do when there's incredible sets of things that are actually worth it? The current regulatory frameworks are not going to be enough to keep healthcare costs down. Okay? We're also going to have AI-led discovery of new therapies. Ideally, there's a lot of interesting work on how AI is speeding up the discovery of drugs, speeding up science use in general. And what is going to happen as we cure more and more disease that's more and more valuable through AI-led therapies. Once again, the existing regulatory framework does not solve the problem. Okay? This is something, the place Europe has the lead is going to break down when in fact we have a bunch of new therapies that are expensive but worth it, instead of what we have now, which are expensive but not worth it. Okay? GLP-1, huge debate. I think we heard yesterday they're just being covered now in France. In our review of countries, in most countries, GLP-1s have not been covered. Okay? GLP-1s are a miracle drug. Okay? They are incredibly successful at those, especially those with pre-diabetes and diabetes. There's still some debate. There's no real evidence that they're necessarily lowering a lot of costs in the near term. But if you look at, for example, evaluations of their value by ICER in the US, they're a valuable drug. They're improving health. They are having effects we may not even realize in terms of dealing with other addictions. I think the mental health benefits of GLP-1s are understated, et cetera. But they're expensive. And how are we going to deal with that? And once we let them into a place like Europe, that's going to be a big expense. How do we deal with that? So basically, this raises the fundamental question for universal healthcare countries, which is, can you be universal if you're not paying for things which can cure the incurable? Okay? That's a fundamental question you're going to face. Okay? So basically, we need new financing models. In the US, I think we need to move towards a single payer model for cell and gene therapy. Now, I realize single payer, I just a few minutes ago talked about what a nasty term single payer was in the US. But in the US does have a single payer system. We have a single payer system for those who have end-stage renal disease. If you have kidney failure, you are covered on a single payer system under Medicare. Why can't we do the same thing for those born with rare genetic diseases? My view is those born with rare genetic diseases, there's no moral hazard problem. Okay, I think this is a perfect case for single payer. We should move towards Europe in that case. But that doesn't solve the problem you all face, that it's expensive. So the other way to think about this is to start thinking about advanced purchase commitment models. Why are these drugs so expensive? These drugs are so expensive because this typical case of high fixed costs, low marginal costs, but the marginal costs are not spreading among many people. So the problem is you have to charge, the average price becomes enormous because the marginal costs are not spreading for enough people. This is a classic case for an advanced purchase commitment model, where we come together and pay a fixed amount, ideally as a prize for curing the incurable in the famous Michael Kramer framework. We say, look, if you develop a drug that cures this, you will win a prize of $1 billion, but then you're going to price it at marginal cost, or marginal cost plus 15%. Okay? I think we need to start thinking about that. That is very, very hard, okay, to do. It's hard to do in two senses. One is, how big does the prize have to be? Well, that is really determined by financial markets. We have to ask, how big does the prize have to be before folks are going to take a risk on developing a new drug? Okay, that's point one. Point two is, if you then want to price it at marginal cost, no one's ever really measured marginal cost for pharmaceutical development before. That's really hard, right? It's made in a big plant that's making lots of other things, etc. So we have two enormous challenges, which is, how do we set an APC? Question? Sorry. Ideally, you coordinate across countries because then the market would be larger. Ideally, you'd have it's a great point. Ideally, you'd have a worldwide APC. Where basically you would, because you're right. That's an excellent point. Once one country's paid for, it's discovered, all the other countries free ride on it. I hadn't even thought of that. You're right. You really need a worldwide APC to make this work. It's a great point. And then basically the idea would be you would essentially have the government, because another important expense is delivery of these gene therapies in particular. So government could contract for delivery and they'd be financed by general revenues. Okay. Now, can this work? Here's one positive example, which is what happened with Hep C in Louisiana. So, funny story about this. I got a call from a reporter from the Wall Street Journal saying, I've been talking to, this is when, so in the 2013, Gilead came with Sovaldi, which cured hepatitis C. It was a miracle. Okay, hepatitis C is a deadly disease, 40,000 Americans dying a year, many more around the world. They came out with a drug that cured it. It was $84,000. So I got a call from a reporter who said, I've been speaking to the head of HHS in Louisiana, and she's complaining about this. And I said, tell her she's an idiot, that basically $84,000 is a bargain. She should give everyone Sovaldi. So I got a call back later. She said, you're from the woman, who was Secretary of Health and Human Services. She said, you're the idiot. Okay, do you realize that to cure Hep C in Louisiana would cost more than we spend on our entire education system? $3 billion a year, because we have so many people with Hep C. But I'm working on a new solution. So myself and Rena Conti and others worked on setting up a new system in Louisiana, which was this called subscription Netflix model, which is essentially, we had Gilead and AbbVie bid against each other for a fixed commitment to eradicate Hep C in Louisiana. So as they bid, and basically Gilead agreed for no more money than the state was currently spending on a limited set of people to provide an unlimited amount of Sovaldi to cure Hep C. And so far, the rate of Hep C eradication has dramatically increased, by far the highest in the country. Estimates are probably we've eradicated about a third of the population in Louisiana. This was really set back by COVID. It kept right before COVID, but it's picked back up. And I have a recent paper with Rena Conti and Jacob Wallace and Kevin Callison, which shows that it more than paid itself back in terms of saved medical spending. So these alternative models can work. These alternative models can work. And I think that the next step for Europe, it comes to this interesting debate we had yesterday about country versus Europe-wide. Your question comes to the debate we had yesterday about country versus Europe-wide innovation. And how do we think about setting up systems? And here's the other piece I would emphasize, which is, I guess there's a fourth thing that makes this difficult, which is the right price depends on the qualities that are gained by curing these diseases. The problem is those qualities rely on very outdated data. So for example, if you look at the ICER report on Zolgensma, ICER is the sort of shadow equivalent of NICE in the US. It's a nonprofit organization that sort of considers drug valuation. If you look at their evaluation of Zolgensma, 200-page report, incredibly well done. But like, it relies on incredibly weak data. Like, for example, you have to ask, how valuable is it that a kid can hold their head up versus not being able to hold their head up? Well, it's worth something. How much? Well, they had one study of 3 people in 1977, okay, to base this on. We need to invest now in saying, what are the diseases we want to cure? Let's work on measuring now the damage they're doing so that we can actually put down an appropriate valuation for curing them. If we want to say what's it worth to cure this disease, we need to first measure what's the damage it's doing. And that's research that needs to be publicly financed and publicly funded ahead of the game. We should really be developing sort of a database, an international database of what's the value of curing these diseases so that when those drugs come along, we're ready to pay the right price. Anyway, I've gone on too long. I'll stop there. Thank you very much.
Well, thank you, John, for the very thought-provoking and fascinating talk. We have some time for questions. I'm sure there are tons of questions, so, all right.
Just quickly, I do a lot of work on Alzheimer's and dementia, and a lot of the costs are outside of the healthcare system. I'm curious if any approaches that you've seen around the world have been able to not perhaps combine, but kind of to consider the implications of healthcare investment or lack of investment into other, say, fiscal domains, partly where informal care or productivity impacts are so huge that perhaps treating rare disease or even obesity would actually pay off, but the healthcare system is not willing to do it efficiently.
You know, it's a great question, enormous challenge that government scorers, so I've worked a lot with the Congressional Budget Office in the US, the government scorers face all the time. And their approach is very conservative, and I think probably right, which is in the absence of convincing evidence, they assume it doesn't exist. So if you ask anybody who advocates for any treatment of anything to support it, the first thing they'll argue is offsets. They'll say, oh, well, if you do this, it'll save the folks who believe in dental insurance, that may or may not be right, but the first thing they say is it stops heart disease. Not like it makes your teeth healthier, but it stops heart disease because everyone wants it to be a free lunch. Now, that may or may not be true, but there's no great evidence for it. So I think that may be right, but I'm worried about that argument. As an economist, I'm worried about the slippery slope of that argument absent evidence. So I think if we really want to argue, so you take, for example, I think a fascinating research topic is the effect of health improvements on productivity. We have almost no evidence on that. Think about that. What could be more important than thinking about the effect of health and productivity? We really have almost no evidence on how making people healthier actually makes them more productive. Okay, that could be a game changer. If we had evidence on that, if we had even a small effect of that, that could massively pay back. But right now, if you go to the Congressional Budget Office, I don't know if the equivalent is in France for scoring legislation, and you say covered with health insurance, they'll give you 0 credit for improving productivity. Okay, so I think that you raise a great point, and there's 2 sides to your point. One point is the effect of improving health in terms of other social benefits. Here, the best data is probably the evidence that Amanda Kowalski and others have done showing that when you expanded Medicaid, 30 years later, people are earning more income. Okay, but there's also the other side of that, which is non-health investments in terms of improving health, housing, food, those what we call social determinants of health. Another great area where there's very little evidence that they actually improve health. So I think these are things where we need a lot more research.
Thanks so much. Excellent talk. Really great. I was wondering, John, how do you see the prospect of the United States to move toward a universal coverage system in, let's say, the next 10, 20 years? And like the follow-up is like, how in that context, how important do you see the issue of regulated prices? And because we have a high share of underinsured people in the United States, which is probably partly related at least to the high prices and not a lot of utilization. So do you think, like, I would love to hear your thoughts on that. It's to me, it feels like we're stuck somewhere after the ACA in that weird equilibrium, and I'm not sure if we find a way out there.
Yeah, I mean, we have this fascinating pattern of almost exactly every 18 years we take up healthcare reform. So we're coming due on the next round. I think that basically there's not a lot more to be done on access other than fighting on the margins about the ACA. Do the Biden subsidies come back in? What do we do about enrollment? I think the access fight is kind of largely over. I mean, the big part of the access fight is the undocumented, but I don't see any way we're taking that on anytime soon. So I think the access fight on the undocumented is largely over. I think the question is, do you take the next step of the coverage fight? There's an obvious step we can take, which is roughly, this is a few years old, but as of a few years ago, under the Biden subsidies, 2/3 of the uninsured were entitled to free health insurance. Free. So why not just default them in? Why not just say, if your tax return indicates that your income and situation is such that you're entitled to free health insurance, then you're defaulted in. We get a letter saying, unless you want to opt out, here's your health insurance. Okay. First of all, we showed in Massachusetts when we auto-enrolled people in health insurance, that can cause that has a terrific effect on competitive bidding across plans. To be the default plan can really bring the bids down. This is kind of a bit like the conversation yesterday we had about default plans. If you get to be the default plan, so it's very strong competitive bidding effect. And you could solve a lot of the uninsured problem. Now, how's that different than a mandate? I would argue, obviously, it's a nudge instead of a mandate because people can always opt out, but we know most won't. Okay. So that would be, I think, once again, nothing's easy, but if you think about potentially feasible steps towards universal coverage, I think that's the next potentially feasible step towards universal coverage. That doesn't solve, like you said, the so-called underinsurance problem. I don't like that term, or affordability, I don't like either, but the high out-of-pocket cost problem. There, I think, once again, the ACA has in many ways solved that problem, which is we need income-related out-of-pocket costs. That's the right way to do it. And that solves that problem. Okay. The ACA has done that in the exchange with income-related out-of-pocket costs. We need to sort of figure out a way to extend that, have more income relation in the out-of-pocket costs. I thought, the paper yesterday which showed that, a small deductible didn't really seem to matter that much. I thought was interesting. There's a big debate. Amy and Laurent have a book arguing we should have no out-of-pocket costs for basic services. I think there's a debate about that. But I think that's sort of a separate issue. And then the biggest issue is regulating prices. Look, I have completely shifted in my career to thinking that the only answer to cost control in America is regulating prices. I think there's no other answer. We've tried other things, doesn't work. What a nightmarish debate. I don't know. We started a little bit, I always said, I didn't know if we'd get to price regulation in the US, but I knew we'd come for drugs first. And the reason is twofold. One is the prices are transparent, and the two is the fucking ads. Okay. Now, my kid was of the age where the first ads for Viagra started showing. Okay. And my kid with 8-year-old would say to me, what's Viagra and why does that man keep throwing that football through the tire swing? Okay. And then that led to one of my favorite all-time stories. We have a friend who's a pediatrician in Lexington, Massachusetts. I swear it's a true story. Andrew heard it. Okay. And he said that a kid came to his office, an 8-year-old, and said, I'd like to talk to you about Cialis. Cialis is an erectile dysfunction drug, for those who don't know. The pediatrician said to the child, why do you want to talk about Cialis? Said, I was watching football and said, talk to your doctor about Cialis. So I like to talk to you about Cialis. So I think there's reasons why drugs came first. They sort of led with their chin. But I think that what's ironic about that is drugs in many ways the last place you want to regulate prices because the most innovative part of the healthcare sector. Hospitals aren't innovative. We should regulate hospital prices, right? Hospitals aren't innovative at all. Drug companies are innovative. I'm not saying we shouldn't regulate drug prices, but it's sort of ironic that we went there first, given that that's probably the most innovative sector we have in healthcare. So I think that, but it's just politically just such a challenge.